So, multiple sclerosis. Good morning to you all. Today, we're going to continue from where we left last week on the nervous system. And as I mentioned earlier to you, we're going to discuss multiple sclerosis today. Then we will continue from cardiovascular because we have more conditions under cardiovascular to cover. So I want us to add this to what we learned last week. So we will finish with nervous system, move on to cardiovascular, then we discuss some conditions under cardiovascular. So that is what we're going to do today. So we have definition and description. We're saying that multiple sclerosis, MS, to be abbreviated, is a chronic degenerative progressive disease of the central nervous system. And this is characterized by small patches of demyelination in the brain and the spinal cord. So here, the condition is chronic. When it comes, that is it. There's no cure for multiple sclerosis. And it is as a result of degeneration of the myelin sheath. Degeneration. So degeneration, when you get degeneration, then something comes to your mind as aging. So as one ages, the brain, the nerves, their myelin sheath degenerate. And then once it degenerates, it brings about the signs and symptoms. And progressive. Progressive means that the condition starts from 1, then the next time moves to 2, then the next time moves to 3 in a progressive order. It increases in intensity. So multiple sclerosis, MS, to be short, is a chronic degenerative progressive disease of the central nervous system. And this is characterized by small patches. So there are small patches, like scratches, on the myelin sheath in the brain and the spinal cord. And when these patches occur on the myelin sheath, it impairs the transmission of nervous impulses. So the nervous impulses require that the myelin sheath becomes smooth. Just as you put a car on an asphalt, it moves on a very steady manner. There is no disturbances. So when you have patches or plaques or inflammation of the myelin sheath, then this inflammation or plaques or patches will disturb the smooth transmission of the nervous impulses. So here, when the plaques or the patches occur on the myelin sheath, then it leads to impairment in the nervous transmission. So it is normally distinguished by exacerbation and remission of symptoms over the course of the illness. We are saying that when multiple sclerosis occurs, at a point you recover, at a point the condition flares up, at a point you recover. That is how it runs. So on and off in that particular manner. So on the screen you see two nerves, one on my left, one on my right. The normal nerve cell or the normal nerve fiber has a nerve cell covered by normal myelin sheath, which has all the sheath intact. There's nothing wrong with the myelin sheath. Then we have the nerve fiber. Then we have the muscle fiber is innervating. So the muscle fiber receiving the nerve impulses from the brain. So that is a smooth nervous transmission or nervous signal transmission. So there's nothing wrong with the transmission of the nerve impulses. Then let's look at the other nerve on the right hand side. There's the nerve cell, there's a myelin sheath which is damaged. Once it is damaged, it's been broken. There are patches on it. So these patches will definitely interrupt the signal or the information that is generated from the brain to the muscle fiber here. So you have signal that is broken into pieces. So you can see the arrow here indicating that there is no smooth transmission of impulses. So the impulses are broken into pieces and you don't have smooth transmission. So it affects and manifests on all the systems of the body. So let's look at the pathophysiology, how the condition occurs. So we have the sensitized T and then the B lymphocytes. When we say sensitized T and B lymphocytes, you are doing physiology, you are doing, so you should know. When these T and B lymphocytes are sensitized, they cross the BBB, the blood-brain barrier. So when they are synthesized or when they are sensitized, sorry, so sensitization means that, like in a normal setting, it might be like you have a barrier and you have seen some foreigners trying to invade a certain part of your territory. So what do? You call on your military to attack them. So when the military is called upon to attack them, that is when the military people are sensitized to act or to fight. So here, before you see the T and then the B lymphocytes being called upon to act in a certain manner, it means that they have seen a foreign body that has entered the body or the brain, and they are going to attack that particular foreign body. So before the B and the T lymphocytes could become sensitized, then there has been an impression that something has entered, some foreign substance has entered the body. So when they are being sensitized, they cross the BBB, which is the blood-brain barrier. And their function when they enter the brain is to go and check on the CNS if there is any antigens and then leave. If there's any antigen, definitely they will act on it and then they will devour it and then they leave. But in multiple sclerosis, what happens is that when the T and then the B lymphocytes enter the cell, the brain cell, they don't leave, they remain. And when they remain, they don't close the door. The door here refers to the blood-brain barrier. They don't close it. So they allow the BBB to remain opened and allow other agents and other foreign particles to infiltrate into the brain and cause damage to the immune system and then the brain. That is what happens in multiple sclerosis. The sensitized B and the T lymphocytes will enter the blood-brain barrier. They, instead of leaving to close the gate, they will remain. And once they remain, the gate also remains open. And then they allow foreign and other agents that will enter the blood-brain barrier and cause damage to the immune system and then the brain tissue. The immune system attack leads to inflammation. So when once immune system is attacked by these agents, then they cause inflammatory process. The antibody definitely will be an inflammatory process. So the inflammation that destroys the myelin and then the oligodendrocyte cells that produce the myelin in the CNS. So this inflammation will cause the patches and cause these plaques to be formed on the surface of the myelin sheath. You know, the oligodendrocytes are those that produce the myelin, so they will also be attacked. So you don't have good production of the myelin sheath, and ones that are produced are also attacked and cause plaques or inflammations on it or patches on it. So demyelination interrupts the flow of the nerve impulses and results in a variety of manifestations depending on the nerves affected. So the plaques appear on demyelinated axons. So here the nerve that is affected will definitely interrupts certain transmission of impulses, and once it happens, there are manifestations that are affected on other parts of the, depending upon where the nerve cell finds itself. So definitely there will be interruption of the transmission of impulses. So demyelinated axons are scattered irregularly throughout the CNS. The areas most frequently affected are the optic nerve. So where we have plenty of these nerves accumulated, then we are talking about the optic nerves, the optic chiasma, and the tracts, the cerebrum, the brainstem, and the cerebellum, and the spinal cord. These areas are heavily dominated by the nerve cells. The axons themselves begin to degenerate. So here the myelin sheath starts, and then the axon, that is the actual nerve fiber, also gets degenerated, and that is a severe condition. So it results in permanent and irreversible damage to the nerve, and then the part of the body will also be affected. Okay. So the cause of the condition, one can start the condition to run in benign course, another one may run in relapsing remitting course, another one may run in primary progressive course, another one may also run in progressive relapsing course. That is the least common. About 5% of the population experience the fourth one. So benign course, here it starts where symptoms are so mild that patients do not even bother to seek care or treatment. You may go unnoticed and nobody may see that you have a problem. Then the second one is the relapsing remitting cause. Here is characterized by periods of relapses. So you get better, then the next day the condition flares up. Then you get better, you recover. Then the next time the condition flares up. So there are periods of relapses. So that is how it happens, relapsing remitting cause. Then we move to the third one, which is primary progressive cause. Here is a disabling symptom, so the symptom becomes worse and worse. And gradually it increases in intensity, with periods where it will flare up and then you get recovered or improve on the conditions temporarily. So there's period of improvement and there's period where the condition flares up and it increases in intensity on a gradual basis. That is about the primary progressive cause. Then we have the progressive relapsing cause, which is also characterized by relapses with continual disabling progression between exacerbations. The difference between the third and the fourth one is that the fourth one starts and it doesn't get better. It starts from 1, it progresses on to 2, 3, 4, 5, 6, like that, and it increases in intensity. So the next attack, the next one, which will be the second attack, will be more severe. Then the third one will be more severe than the second. That is how it graduates in intensity. So you see there's continuous disabling progressive between exacerbations. So the condition doesn't get better. It worsens from stage 1 to stage 2 to stage 3 to stage 4. That is how it happens here. There is no period of improvement or recovery. So clinical manifestation, we have the fatigue and weakness. Definitely when the nerves are not innervating the muscles or the muscle fibers well, there will be weakness, there will be fatigue. Abnormal reflexes, they are absent or exaggerated because of the improper transmission of the impulses. Vision disturbances, so you could have impaired and or double vision. Motor dysfunction, here you have weakness, tremor may be exhibited, incoordination in movement and activities. Sensory disturbances, so we have paresthesias. You are there, you feel like there's numbness, there is tingling sensations, so that is paresthesias. So you feel numbed. Impaired speech, slurring of speech. So when you are speaking, your speech becomes very, very slurred because of the part of the nerve that is affected. Scanning or dysarthria. So here, when you are moving, it becomes difficult. Urinary dysfunction. So here, there is hesitancy, there's frequency, there's urgency, and there's retention. Here you have to note the difference. Okay? Hesitancy means that the moment you want to pee, it will delay for a while before the urine flows or start flow or comes. Then the frequency, the number of times you visit the washroom. The urgency is the need to do it. If you don't rush to the washroom, your clothes or your attire will get wet. So there's that urgency for you to rush to the washroom and then empty the bladder, because the nerves that supply the bladder has become affected, the myelin has become affected. And there's retention. So retention means that the nerves, the stretched nerves that are innervating the bladder, urinary bladder, is not really supplying impulses to the brain. For the brain to know that the bladder is full, and therefore you have to go and then have the urge to pee. So there's retention because of the destroyed nerves. Neurobehavioral symptoms. So here there's depression, cognitive impairment, and emotional liability. So diagnostic investigations, we can do MRI to visualize small plaques to see which of these plaques are destroying the myelin sheath. CSF analysis review elevated immunoglobulin G levels because of invaded microorganisms through the BBB. So there will be elevated immunoglobulin G. Evoked potential studies demonstrate slow conduction of nerve impulses in 80% of MS patients. So patients experiencing multiple sclerosis, studies demonstrate that the impulses transmission are very, very low. 80% of them, they are very, very low. Then we have abnormal immunoglobulin G antibodies. That's the oligoclonal bonding. We have these abnormal immunoglobulins plenty in the blood. That shows that there has been an attack on the myelin sheath. Electrophoresis study of the CSF shows abnormal immunoglobulin D antibodies. So abnormal immunoglobulin D may be seen when you do oligoclonal bonding, and you also do electrophoresis study, and you see that the CSF also have a lot of IGF, IgG antibodies. Sexual history helps identify changes in sexual function. Definitely, because of the affected nerve, there will be problem with sexual history. So sexual behavior may be impaired, and once you listen to the history on sexual behavior, you can conclude on that. Neuropsychological testing may be indicated to assess cognitive impairment. Once they subject you to neurological studies or testing, definitely there will be some impairment, and that will where they will diagnose that you have a problem with multiple sclerosis. Treatment: there's no cure. There is no cure. If anybody says he will cure you of multiple sclerosis, say who? There's no cure. The aim is to relieve symptoms and help the patient to function. Basic functions is what you want to achieve. So immunosuppressive agents may stabilize the cause. So if they are thinking that they want to stabilize the attack on the immune system by suppressing the immune system, so they will give you the immunosuppressive agents to stabilize the cause of the condition. If they find it out that your immune system is attacking the myelin sheath excessively, then they will stabilize it by giving you immunosuppressive agents. Then we have the clothiazepozide, which is also to mitigate the mood swings. So this is normally called Librium, and Librium is given so that you can have some kind of mood stabilization. Then we have the baclofen, is the medication of choice for treating spasticity. So because of the abnormal impulse transmission, the patient experiences some kind of spasticity. So here, spasticity is where you experience some kind of rigidness at the joints. And benzodiazepines or Valium or Xanidine and dantrolene may also be useful to treat spasticity. Then we have the beta-adrenergic blockers, which is more or less an antihypertensive, and anti-seizure agents and benzodiazepines to treat ataxia, that is abnormal movement. So these medications are given to help control the movement of the person with MS. So nursing management here, our aim is to promote physical mobility. We said there will be ataxia or difficulty in movement. So we perform muscle stretching and strengthening exercises daily so that the stiffness will be reduced. We apply ice packs before stretching to reduce spasticity. So definitely the tendency for you to experience that. So once you want to avoid spasticity, you have to apply some ice packs so you don't subject the patient to by heart spasticity. Okay, tell patient to avoid muscle fatigue by stopping activity just a short of fatigue and to take frequent rest periods. So because they are prone to muscle fatigue and weakness, when they do activity for a while, you let them stop and then rest for a while to continue. That's it. So they don't experience so much fatigue and then muscle weakness. Encourage ambulation and activity. So it's difficult to move, or when you are moving, they find it difficult. So encourage them to move about. So they may reduce the spasticity. So you teach them how to do early ambulation, and small passive movement is also encouraged. Teach patients how to use such devices as braces, canes, and walkers when necessary. So when they are trying to initiate movement, initially they can be given these walking aids, braces, canes, and walkers to aid them in movement. Inform the patient to avoid sudden changes in position because they have problem with the brain. So it's possible they can even fall and experience dizziness. It may cause falls due to loss of position sense and to walk with a wide-based gait. When they are walking, they should walk with their legs a bit wider so that they can have a firm ground on the floor so that they don't fall down. Preventing injury, teach patients to walk with feet wide apart to increase walking stability. I just mentioned it. If coordination exists, or if the patient is not stable, you should always walk with the legs a bit wide. So teach patient to watch the feet while walking if there is a loss of position sense. So once the patient loses position, you should watch when he's walking so that at least he can balance the movement without falling. Provide a wheelchair to motorized scooters if gait remains insufficient. If the patient has a problem with gait, then definitely we need to provide a wheelchair, just as our former President Kufuor has been given. He has a problem with the gait. So when he was walking initially, you see two strong men walking beside him to stabilize him because he has lost the gait. and therefore they have to finally provide him with a wheelchair to help move about. Assess scheme for pressure source if patient is confined to wheelchair. So if the patient cannot move about, make sure that you treat the bottom or you treat the buttocks to prevent pressure source, because always the pressure is at the buttocks. So make sure that you massage to improve circulation as much as possible to prevent a pressure source occurring. Encourage patient change in position while mobilizing to prevent contractures. So here you need to massage the joints, you need to do a lot of muscle massage for this patient, all to prevent or minimize muscle contractures. You are enhancing bladder and bowel control. We said the nerves supply the bladder and then the bowels. So you keep bedpan and urinary readily available because the need to void must be heeded immediately. Set up a voiding schedule with gradual lengthening of time. So here you are doing something like toilet training, and that is good. Toilet training is good. So here, train the bowels. Make sure you train the bowel, but make sure the bedpan is within the reach of this patient. When he calls for it, you delay a bit and then you give it. So it's all about training the bowels. Okay, so you set up a voiding schedule with gradual lengthening of time interval. So first you start with about 5 minutes, then like go to 8 minutes, 10 minutes gradually. You train the bowel. Instruct patient to drink a measured amount of fluid every 2 hours and to attempt to void 30 minutes after drinking. So here is a form of training the bowels. Provide adequate dietary fiber and a bowel training program for bowel problems like constipation, fecal impaction, because the nerves are not innervating properly. The patients, most of them are having constipation, and there's poor peristalsis, and definitely if there's poor peristalsis, definitely there will be constipation. So you give food high in fiber to help resolve some of these constipation and fecal impaction. Encourage patients to take prescribed medications for bladder spasticity. So these relaxation medications are available. Once they have this spasticity of the bladder, they can be given these medications, and therefore the bladder spasticity will also be reduced. Assess for urine retention and catheterize for residual urine as indicated. So make sure the patient empties the bladder. If you still have some urine retention, then you have to catheterize the patient to help drain, because the nerves cannot do everything. Once it has these patches on the myelin sheet, it cannot empty, because the urge to do it may be slowed down. So you always have some urine in the bladder. Promoting sexual fun. Encourage open communication between partners. Discuss birth control options if appropriate. Once you have this condition, then you have to talk to your partner, because it's not likely your partner may have the urge to even have sex. Discuss birth control options. Yes, use some appropriate contraceptives, or suggest sexual activity when patient is most rested. Yes, it's not all the time the patient may have the attack. When the patient is in a very good state, then you have to discuss sexual activity and let the patient understand. Suggest consultation with sexual therapists to help obtain greater sexual function. So the sexual therapist may also understand the need to go to your partner when he is in a restful state and discuss sexual activity with the partner. So this can be aided by the sexual therapist. Improving sensory function. Measures may be taken if visual defects or changes in cognitive status occur. The cranial nerves affecting vision may be affected by multiple sclerosis. Of course, if the nerve supplying sensory to the eye is affected, definitely there will be a problem with vision. An eye patch or covered eyeglass lens may be used to block the visual impulses of one eye if the patient has diplopia. So if there is diplopia or double vision, then they will use aid to cover one eye and then try to test the other eye or reduce the problem with double vision. Prism glasses may be helpful for patients who are confined to bed and have difficulty reading in the supine position. So they'll give you special glasses for you to read in the very supine position. People who are unable to read regularly or regular print materials are eligible for the free talking book services of the Library of Congress, or may obtain large print or audio books from local libraries. I remember the last stages of former President Mills, they print something for him to read. It is so big because he had problems with vision and reading was problematic. So they have to print it either so large for him to read the letters there, or they will have something like talking book. When you put your hand there, then it will be reading the thing for you. They have that material also available. So these things can be done to help you read and read better. Improving cognitive function. So here, cognitive impairment and emotional liability occur early in multiple sclerosis in some patients and may impose numerous stress on the patient and the family. In fact, if there has been a cognitive problem with multiple sclerosis, then it gives the family a lot to be concerned. Some patients with multiple sclerosis are forgetful and easily distracted and may exhibit emotional liability. Yes, they are not comfortable at all. So with the least distraction and stress, you cause problems emotionally, and then they start getting stressed up. So that is what happens. So make sure that you don't distract them, you don't irritate them, you calm them down all the time. Patients adapt to illness in a variety of ways, including denial. So initially they may deny, oh, nothing is wrong with me, nothing. Meanwhile, you are sick. And especially the men, they don't want to mention sickness at all. So they will be saying all sort of things. Oh, I'm not sick, I'm okay, but they are sick. So initially there will be denial, then there will be depression, withdrawal, and hostility. Hostility comes as a result of the frustration. Yes, so they'll go through all these emotional problems. Emotional support assists patients and their families to adapt to the changes and uncertainties associated with multiple sclerosis and to cope with the disruption in their lives. So, there has been emotional change, and therefore you need emotional support, you need family support, and the family and you should understand and adapt to the new change. There has been a change, and you need to adapt and cope with the new change. Okay. The family should be made aware of the nature and degree of cognitive impairment. Here, to what extent is our client experiencing cognitive impairment? Is this stage 1, stage 2, or stage 3? The family should be made aware that this is the extent of cognitive impairment experienced by your patient. Patients with multiple sclerosis have identified that the support of family and friends is a primary need. You need the family. You need the support from the family. You need the support from friends. You need the support from the immediate ones, so they can do everything for you without feeling any frustration. That is where you see human beings are very important. You may have all the monies in the world, but you may not have the best of care. But once you have a family who cares, you may not have so much money, but they'll give you the best of care. This is the difference between family and other house relatives. Yes, if people have a family, you could see in difficult times the family stand up for them. But people have homes, they don't have families. They have houses, they don't have families. And this is the difference. In a difficult situation, how does the family stand for you? In difficult situation, do you see your family member giving you the maximum support? It's very, very crucial. The patient is assisted to set meaningful and realistic goals, to remain as active as possible, and to maintain interest and activities. So the patient is made to set right now goals that he cannot achieve, but you set goals that he can achieve and goals that are realistic, so that there will be that kind of achievement in goals, and therefore the patient may be happy that certain goals have been achieved. If you set goals that are not achievable, it will affect you and may even affect your mood. So the complications of multiple sclerosis may range from urinary tract infection because of the poor bladder elimination, constipation because of lack of peristalsis, pressure sores because you are sitting at one point, you cannot move, and there will be pressure on the muscles. There will be pneumonia because of poor respiratory system. You are not active, and therefore the possibility of getting respiratory infections are high. Reactive depression, they react to the external environment, and that may depress them, especially if you have a very annoying relative who will cause reactive depression. Sexual dysfunction, we talk about that. Then dependent pedal edema, especially when there's poor venous return and there's pitting edema, it means that the condition has advanced and probably it has affected the respiratory system and it's giving you complications of respiratory system failure, and that is right-sided heart failure. All these signs are very, very common with respiratory disorders. So, are there any questions? If you just write down your question, anything that you want to ask in this particular lecture, put it down, write it down. At the appropriate time, I will give you the opportunity to ask these questions for more elaboration and contributions and answers. So just put it down so that we can continue. So we move from multiple sclerosis, which was one of the nervous system conditions that we discussed. We are moving on to cardiovascular. And at the cardiovascular, our first topic that we'll discuss will be atrial dysrhythmias. You can call it atrial arrhythmias or atrial dysrhythmias. So that means that there's abnormal electrical discharges at the atrial side of the heart. So the atrial dysrhythmias originate. We have to know where the problem originates. Originate in the atrial tissue or in the internodal pathways. So if you look at the heart, the right side of the heart, the right atrium, just around the right atrium, there is a pacemaker that initiates impulse of transmission. And that is where we have the SA node situated. And within it found is the pacemaker. They are the most common types of dysrhythmias, particularly patients or persons older than 60 years of age. So atrial dysrhythmias normally affect people who are older than 60 years of age. So an atrial dysrhythmia is an abnormality that occurs in one of the two chambers or upper chambers of the heart. So if you look at the heart, we have two upper chambers and then the two lower chambers. So we are saying that according to the name atrial are the two upper chambers, the left and the right atrium or atria. So single is atrium and plural is atria. So that when it occurs in these two upper chambers of the heart, the left or the right atrium could also be in. That is the two chambers that are found in the heart. And atrial dysrhythmias arises in the atrial of the heart or the atrial of the heart. So we have atrial dysrhythmia beginning from the atrium of the heart. If the dysrhythmia causes the patient to lose the atrial kick, so if the dysrhythmia causes the patient to lose the atrial kick, so when you lose atrial kick, what does that mean? We mean that instead of a fire to be released from the atrium to move down to the ventricles to cause ventricular contractions, you will miss that electrical discharge. So when you miss that impulse will not be released. You miss it. So once you miss it, there will be no contraction. So you have missed a kick. So once you lose the atrial kick, it means there has been a miss of the atrial fire, and the electrical impulse that's supposed to be released to go and cause ventricular contractions have failed to be released. So we say you have missed an atrial kick. Because anytime the ventricles contract, remember it is the impulses that are generated from the SA node that travels down to the ventricles will cause the ventricular contractions. And once the ventricles contract, the contents are ejected out of the ventricles. Then there will be relaxation until another cycle is repeated. So once you miss a kick, it means you have missed an impulse that's supposed to go and initiate the contractions. The blood that is ejected into the ventricles during atrial systole. So that is what I have explained. So you miss this blood. So this blood accounts for about 35% of the total end diastolic volume. So you miss that blood that's supposed to be ejected into circulation. So the patient may have more symptoms when you miss this kick. The atrial kick provides approximately 35% of the total end diastolic volume, which is an essential contribution to ventricular filling in individuals with heart diseases. So once you miss a kick, then it means that blood that goes out will be less. and therefore blood that you are receiving or that is filling the heart chambers will also be less. So it means that you are going to have problems with circulation. That is the meaning. So ventricular filling in individuals with heart diseases will be severe. Atrial dysrhythmia that cause the loss of the atrial kick include the atrial flutter and atrial fibrillation. So the two atrial flutter and fibrillation are those that will cause the atrial kick to be missed. This is a diagram that explains how the sinoatrial node is situated on the 1. So the numbers you see, the 1 is the SA node. Then we have the 2, which is the right atrium. So at the side of the right atrium, that contains the SA node. So before you move from the atrium to the ventricles, down here, we have a junction here. It's called the atrioventricular node. So here, that is number 3, atrioventricular node. So that is the junction between the atrium and then the ventricle. The 4 is the bundle of His. It also helps in transmission impulse from the atrium to the ventricles. Then we have 5, which is the left atrium. So the left bundle also contributes to the left contractions of the left muscles of the heart. Then the right bundle also contributes to the right contractions of the right ventricles. Then we have the other indications. So we have types of atrial dysrhythmias. Atrial dysrhythmia is classified not only by where they originate, that is either atria or the ventricles, but also by the speed of the heart rate they cause. Is the speed low or the speed is high? They are basically classified into 2 main groups, namely tachycardia. This refers to fast heartbeat when the heart is resting. Then if it beats more than or greater than 100 beats per minute, then we are saying that you have tachycardia or tachycardia. So a resting heart, and when the rate is greater than 100 beats per minute, you have tachycardia. Then bradycardia also refers to a slow heartbeat, a resting heart that is less than 60 beats per minute. So when you have rested and your heartbeat is still lower than or below 60 beats per minute, then you have bradycardia. So we have another type of atrial dysrhythmia called atrial fibrillation. I've told you that these two, the fibrillation and the flutter, will cause one to miss the kick and bring about atrial kick. So atrial fibrillation. In atrial fibrillation, the atrium, the upper chambers of the heart, are in a state of electrical chaos. When we say you are in a state of electrical chaos, you understand. And there's no rhythm, there's no control. Everybody does everything anyhow. So there's no coordination. So there's electrical chaos. This muscles will release more electrical impulse, that muscle will release one, that muscle will release one. So there's no coordination, electrical chaos. And it causes them to quiver. It quivers more than 600 times per minute without contracting. So when something is quivering without contracting, it's just shaking without any force to push the blood forward. So there's no force. So it's just quivering. And it does that 600 times per minute without contracting. The ventricles, the lower chambers of the heart, do not receive regular impulses and contract out of rhythm. So once the ventricles are waiting to receive the impulse that has been generated from the atrium, it doesn't normally, in atrial fibrillation, the ventricles do not receive the impulses, and therefore they use their mind that even though we haven't received the impulses, let us contract on our own. When they start doing that, then they contract out of rhythm or out of order, and that is what brings about atrial fibrillation. When the ventricles contract without coordinating from the atrial impulses, then they will contract out of rhythm or out of order, and that is where there will be irregular contractions. So the ventricles, the lower chambers of the heart, do not receive regular impulses and contract out of rhythm, and the heartbeat becomes uncontrolled. So when it contracts out of rhythm, that is where the heartbeat becomes uncontrolled and irregular. It is the most common atrial dysrhythmia. So in all the atrial dysrhythmias, about 85% of people who experience atrial dysrhythmias are older than 65 years of age. They are either 65 or older than 65 years of age. That is, those who experience atrial dysrhythmias. 85% of them are older than 65 years of age. Then we have atrial fibrillation can cause blood clot to form because the ventricles are in a state of electrical confusion, or they are contracting out of order, so it's not strong contractions. So what happens to the ventricles is that they don't contract with any force. So the content of the ventricles cannot be ejected or into circulation. So at every point in time, after contraction, some amount of blood is left within the chambers. And once there's residual blood left within the chambers, they create some sort of sedimentation, and this can cause clot to form. So once the clot starts forming, that is where the blood stream, or it results in stroke. Clots will be formed within the bloodstream, and that will bring about the stroke. So underlying heart disease or hypertension increases the risk of stroke from atrial fibrillation, as does age. So if you have any underlying condition, it will accelerate the stroke formation, apart from the age that we talk about. Now, another type here is called premature atrial contractions, abbreviated as PAC. Premature atrial contractions, abbreviated as PAC. So a common and benign arrhythmias. So it's a very common and it's benign arrhythmia. A PAC is a heartbeat that originates away from the SA node. So we should have PACs, or we should have electrical impulses, and that impulse should originate from the SA node. But at a point in time, you have some impulses originating around the atrium but does not come from the SA node. This is what we refer to as premature atrial contractions, abbreviated as PAC, or premature atrial impulses. So you have any heartbeat that originates away from the SA node is referred to as PAC. It sends electrical signals through the upper chambers, of course, because they start releasing these impulses at the upper chambers. Cardiac contractions initiated in the atria occur earlier. So cardiac contractions that have been initiated in the atria will occur earlier than expected. So here, its impulses will occur earlier than the normal SA node impulses. The underlying rhythm is regular, with the early beat producing a slight irregularity. It typically occurs after the sinus node has initiated one heartbeat, and before the next regular sinus discharge, a PAC will form. Or a PAC can cause a feeling of escaped heartbeat. So you initiate a normal SA node impulses, then you go to the resting period. Before you initiate another normal SA node, another impulse from the SA node, then you see the PAC coming in here to start the whole process. And once you see that, then you know it is a premature. That is what we call premature. Like you are struggling too much. You are struggling too much. Cool down. Take your time and allow the SA node to initiate its own impulses. So we call premature atrial impulses. They rush to initiate impulses ahead of the normal sinus impulses. A PAC can cause a feeling of skipped heartbeat. So if you experience a PAC, it can be easily taken as you have skipped a heartbeat, like the skipped beat. Use of caffeine can cause this. Those who like taking coffee. One of our friends, a lecturer here, he always takes coffee, even in the afternoon. He will take coffee in the afternoon. So, we're saying that a PAC can cause a feeling of skipped heartbeat. So, when you experience a PAC, it can behave as if you have had a skipped heartbeat. And people who normally experience PAC are those who take coffee, tobacco smoking, alcoholism, stress. A lot of stress can also bring about PAC, can bring about or increase their frequency to occur. Then we have another type called supraventricular tachycardia, SVT. So it's characterized by rapid heart rate that ranges between 100 and 240 beats per minute. So once you are experiencing supraventricular tachycardia, then the heartbeat is within 100 and 240 beats per minute. So SVT usually begins and ends suddenly. SVT occurs when an electrical impulse re-enters the atrial muscles. So once the SA node with the pacemaker release electrical impulse, instead of it transmitting down through the bundle of His to the internodal pathway to be received by the ventricles that has the Purkinje fibers to initiate contractions. Here, when the impulse is released from the atrial, then it enters the atrial muscles again and cause another contraction. So within 1 minute, you have several heartbeats that is initiated by these electrical impulses. So this happens when electrical impulse re-enters the atrial muscles and initiate another electrical impulse transmission. A disorder that a person may have at birth. So this can be congenital. SVT can purely be congenital. At birth, it could be there. It's commonly caused by a variation in the electrical system of the heart. So here you may be born with the SA node or the pacemaker, which has a problem from birth, and that will initiate abnormal impulses right from birth. It often begins in childhood or adolescence and can be triggered by exercise, alcohol, or caffeine. So it could be there from childhood but can be triggered by these risk factors. SVT is really dangerous. It's not that dangerous, of course, but can cause a drop in blood pressure. So here, the problem here is that your blood pressure could be as low or as possible. Always could be as low as possible, causing lightheadedness or near fainting. So once you don't have the normal blood pressure, you may be having a very dizziness, or you show signs of dizziness or lightheadedness or near fainting episodes. And really fainting episodes can also occur. So we have atrial flutter, and differentiated from atrial fibrillation by its coordinated regular pattern. Or atrial flutter is a coordinated rapid beating of the atria. Most of the people who experience atrial flutter are over 60 years and older and have some heart disorders such as heart valve problems or thickening of the heart muscle. So people with atrial flutter are those who have atrial fibrillation, or maybe there is regular pattern, there's the fibrillation is coordinated, and they have pattern of beat. So here there is a coordinated rapid beating of the atrium. If there is nothing irregular about this one, so the flutter is differentiated by the fibrillation by its regular and coordinated manner. Just that the beat is fast. So flutter. The beat is as if you are fanning a fire. You are using a fan to fan a fire. That is flutter. So SVT is really dangerous but can cause a drop in blood pressure and lead to these conditions. So here we are saying that the flutter normally occurs, and that is when it's coordinated and regular, and that is how it can be differentiated from the fibrillation. And here, just that the beating is fast. Yeah. So most people who have experienced atrial flutter over 60 and older years, and these people have problem with the heart. They have an existing heart problem, and it could be thickening of the heart muscle or problem with the valves. As with atrial fibrillation, atrial flutter increases the risk of stroke. So they all end up with some evidence of stroke. And that type is sick sinus syndrome, SSS. Sick sinus syndrome, SSS. So common among older people, SSS is an improper firing of electrical impulses caused by diseases or scarring in the sinus node. So here there is either an inflammation or scar tissue that has deposited or that has affected the atrial or the SA node that is responsible for initiating the electrical impulses. So it has reduced the power of the impulse that is supposed to be generated from the SA node. SSS normally causes the heart rate to slow down, but sometimes it alternates between abnormally slow and fast. So the 6 sinus syndrome always slow down the heart rate, and sometimes there's alternation between, or there's between slowing down and then beating abnormally, and sometimes slow and fast. So it could be slow, sometimes it could be fast at a point. SS is a progressive condition with episodes increasing in frequency and duration. So it also progresses from stage 1, it moves to stage 2. If you don't correct it, move to stage 3, then the condition will be increasing in intensity and in frequency. So that is it. So duration wise and frequency wise, it all increase. Then we have another type called sinus tachycardia. Sinus tachycardia. With sinus tachycardia, the sinus node emits abnormally fast electrical signals. The sinus node emits abnormally fast electrical signals. So here, the electricals that are coming is abnormal and it's fast, which increases the heart rate to between 100 beats per minute to 140 beats per minute at rest. So there's abnormal fast electrical impulse that is generated at rest. You are ranging between 100 to 140 beats per minute at rest, and 200 beats per minute during exercises. That is how sinus tachycardia is normally graduated. So here at rest you have a beat around 100 to 140, and during exercise you'll be ranging around 200 beats per minute. Sinus tachycardia is generally the result of increased stimulation of the sympathetic nervous system and the resulting release of catecholamines. So the sympathetic hormones would definitely cause the sinus tachycardia. So it simply means that there's pouring out of sympathetic hormones, and definitely that will raise the heart rate, and that will stimulate the SA node to produce more fire, thereby producing abnormal fast electrical signals and ranging around 140 at rest and 200 during exercises. So always there is sympathetic nervous system activation and the release of the catecholamines, and these catecholamines will end up releasing the epinephrine, the norepinephrine, the adrenaline to cause an increased heart rate. It can also be a normal response to an increased demand for oxygenation. Sometimes you need oxygen and the body will adapt by making you breathe faster, especially after severe exercises. The body will stimulate itself so that you can breathe faster to take out more carbon dioxide. So sometimes the body's own attempt to correct underlying disorder, or as in exercise or fever, or in response to a decreased cardiac output. So sometimes you want to increase the heart rate, you want to increase cardiac output, and therefore the sympathetic action will pour in so that cardiac output will be increased. As in congestive heart failure or shock syndromes, it can also, in congestive heart failure, there's always a mechanism, what is called compensatory mechanism. One of them is the stimulation of the sympathetic nervous system activation, so that it will help to come and increase the cardiac output, even though the heart is failing. But one of the compensatory mechanisms is that it stimulates the sympathetic nervous system activation to pour out the catecholamines to increase the heart rate. It can also occur in response to stress. Yes, once you understand anxiety or an intake of caffeine, nicotine, or anticholinergic medications. All this can also cause the heart to increase its activity. So there's another one called the sinus bradycardia. Sinus bradycardia, and this is associated with impaired impulse generation in the SA node. Sinus bradycardia causes the heart rate to decrease to fewer than 60 beats per minute. So here there is impaired SA node, and therefore the electrical impulse is more or less restricted to a beat which is fewer than or less than 60 beats per minute. The heart rate less than 60 beats per minute has a rhythm that is regular, with the electrical impulse originating in the SA node. So here the electrical impulse here is regular, just that the beat is below 60 beats per minute. Sinus bradycardia is primarily caused by an excessive parasympathetic response. You know, the sinus tachycardia was as a result of increased sympathetic nervous system stimulation. However, the sinus bradycardia is also as a result of parasympathetic response stimulation. It can be a normal asymptomatic occurrence in a healthy individual, as occurs in athletes, or a desired medication effect with drugs such as digoxin and verapamil. So sometimes people who have taken digitalis or digoxin or verapamil may experience sinus bradycardia, or athletes who have a very strong cardiac output may decide to beat at a slower pace, because at each contraction the amount of blood that is sent to circulation is enough to allow the heart to rest before it initiates another cycle. In athletes and those who are very active, the heart muscle doesn't need to contract faster to supply blood to the general body. At one beat, the cardiac output is enough to cover the whole body. So the heart has the time to rest before it initiates another cycle. So some of these conditions is more evidenced in people who are stronger, who are athletes, who always do a lot of exercise. Causes. Each type of atrial dysrhythmia has specific cause. As listed previously, certain conditions can lead to or cause an arrhythmia, which include scarring of the heart tissue from a prior heart attack. I've told about I've told about the fact that sometimes heart attack or scar tissue can initiate this process. Changes to your heart structure, such as from cardiomyopathy, so that your heart may become bigger and the size and shape of the heart may change. Blocked arteries in your heart, so when you have coronary artery occlusion, can also lead to this condition. High blood pressure, overactive thyroid gland, that's the hyperthyroidism, will definitely release these catecholamines. So there will be hyperactivity, a whole lot. Underactive thyroid gland, that's the hypothyroidism, can also cause bradycardia. Other things that can cause dysrhythmias include smoking. Those people who are used to smoking, drinking too much alcohol and caffeine can also lead to this condition. Drug abuse, stress or anxiety, unnecessary stress, unnecessary emotions, unnecessary anxiety can lead to this condition. Then the pathophysiology here, we are saying that the rhythm of the heart is normally generated and regulated by the pacemaker. We all know that the heart rhythm and the ability for the heart to initiate any rhythmic contractions is the sole responsibility of the pacemaker. And this pacemaker is found within the SA node, and is located within the wall of the right atrium. SA node pacemaker activity normally governs the rhythm of the atrial and then the ventricles. When the rhythm or the prior electrical impulse initiated at the atrium, it will move down to affect the ventricles. Normal rhythm is very regular with minimal cyclical fluctuations. It doesn't have any disturbances or fluctuations. Very, very regular and rhythmic. Furthermore, atrial contractions is always followed by ventricular contractions. It's the normal heart. That is how the heart works. The heartbeat starts with the atrial contractions and it is followed by ventricular contractions. When this rhythm becomes irregular, too fast, which is tachycardia, or too slow, which is bradycardia, or the frequency of the atrial and ventricular beats are different, this is called an arrhythmia or dysrhythmias. So anything that is different from the normal is called arrhythmias or dysrhythmias. The term dysrhythmia is sometimes used and has a similar meaning if the abnormal electrical activity causing the irregular heartbeat is generated in the atrium of the heart. It is termed atrial dysrhythmia. So if the heartbeat generating from the atrium of the heart is different from the normal rhythmic contractions, we term it as dysrhythmias or arrhythmias. Clinical manifestations here. So noticeable dysrhythmia symptoms may include tachycardia, which is fast, it could be bradycardia, which is slow, could be chest pain, shortness of breath. Other symptoms may also include anxiety, fatigue, lightheadedness or dizziness, sweating, fainting or syncope or near fainting. How do we diagnose people with these conditions? Medical history. When we take your history, we can have an idea. Physical examination from head to toe can also give an idea. Electrocardiogram, ECG, non-invasive test records the electrical activity of the heart. So after ECG, definitely the results will be there, whether it's sinus tachycardia or sinus bradycardia or whatever, it will be diagnosed. Holter monitor, an ambulatory ECG. The device records the heart activity for 24 hours or longer when you are doing activity or when you are at rest. So it picks up impulses over a 24-hour period. Event recorder. This portable ECG can be activated when a patient experiences symptoms of a fast heartbeat. It is intended to monitor heart activity over a few weeks or months. So those that can go beyond 1 week are also given to record the heart activity over weeks or months. Implantable loop recorder. This is also implanted. A recorder can be used to diagnose patients with recurring and unexplained arrhythmias episodes. So they fix it there and it keeps recording everything. And then echocardiogram can also be used to diagnose this condition. Then we have treatment of atrial dysrhythmias. The dysrhythmia needs to be identified and appropriate treatment started because we have different types. Which type are you diagnosing and which type are you treating? Trials of various medications or combinations of medications may be used to control the dysrhythmias if patient is symptomatic. So once patients are symptomatic, definitely you need to diagnose them and treat them. Low flow oxygen by nasal cannulas or mask is often prescribed for patients during tachycardia arrhythmias. So patients who are going through rhythmic or tachycardia arrhythmias or whatever problem they are facing, first give them the oxygen they need. Some patients may require cardioversion or a synchronized counter shock for atrial dysrhythmias that are resistant to medical therapy. So sometimes they don't respond to medical treatment and therefore they can use cardioversion or synchronized counter shock can be done to synchronize the electrical activity that is moving along the heart. Then treating bradycardia. What do we use to treat bradycardia? If slow heartbeat bradycardia don't have a cause that can be corrected, doctors often treat them with a pacemaker because there aren't any medications that can reliably speed up the heart rate. So people have a lot of pacemaker inserted just to correct the slow heartbeat. That is it. They are there. They just have the heartbeat being slowed down, and therefore it can be corrected by inserting the pacemaker, and that will be okay for the person. So when you want to treat tachycardia, what do you do? But for bradycardia, we say we have to insert the pacemaker. For tachycardia, treatment may include one or more of the following: vagal maneuvers. So we normally look at the vagal maneuver, and arrhythmia that begins above the lower half of the heart, that the supraventricular tachycardia, may be stopped by using particular maneuvers that include holding breath and straining, drinking, or dunking the face in ice water or coughing. So once you put your face in ice water, or once you start coughing, or once you hold your breath for a while, then definitely you are trying to stimulate the vagal nerves to relax, and they can cool down the tachycardia and bring it to a normal reading. These maneuvers affect the nervous system that controls the heartbeat, that the vagus nerve, often causing the heart rate to slow down. However, vagal maneuvers don't work for all types of arrhythmias. So vagal maneuvers may work for certain types of arrhythmias, but not all the types of arrhythmias. Medications. So apart from vagal maneuvers, we have medications for certain or many types of tachycardia. There may be prescribed medication to control the heart rate or restore the normal heart rhythm. It's very important to take any antiarrhythmic medications exactly as directed in order to minimize complications. So administering antiarrhythmic medications for suppressing dysrhythmias or arrhythmias include, if you want to use medication to control arrhythmias, the first one is beta blockers, the calcium channel blockers, the guitars, and antiarrhythmic agents. All these medications affect the heart electrical activity. People with atrial fibrillation are typically prescribed on anticoagulant to minimize their risk of clotting and stroke. We said earlier that because of the slowdown activity, blood may become congested or stagnant within the chambers. Possibility of clot formation is high. So anybody who is experiencing arrhythmias is given anticoagulant to prevent the possibility of clot forming and causing stroke. Then the pacemaker. This small electronic device is surgically implanted under the skin near the collarbone. The pacemaker regulates a slow or erratic heartbeat by sending rhythmic electrical charges to the right atrium and the right ventricle. So the work of the pacemaker is to send regulated rhythmic electrical charges to the atrium and then the ventricles. So cardioversion can be used in atrial fibrillation. This procedure restores a normal heartbeat by transmitting a brief electrical shock through the chest to the heart. This resets the rhythm to a normal, but does not fix any underlying problem that predisposes the patient to an arrhythmia. So it will reset the electrical activity to a normal rhythmic, but if there is underlying problem, like thickening of the muscles of the heart, or like a blocked valves or whatever, this cardioversion will not correct it, but it will just reset the irregular rhythm to a normal rhythmic contractions, but it will not resolve any underlying cause. That is the cardioversion. The radiofrequency catheter ablation. So here, for this minimally invasive treatment, a catheter with an electrode tape is positioned on the affected area. The catheter delivers energy to strategically destroy tissues that is interfering with the normal transmission of electrical impulses through the heart. It is most commonly used for supraventricular tachycardia and atrial flutter. Yes, so if there are other tissues around the atrium that is initiating electrical impulses that could interfere with the normal impulse from the SA node, then they will use radiofrequency catheter ablation to destroy those tissues or those structures that are releasing electrical impulses to confuse the normal electrical input that is being initiated by the SA node. So this is done to strategically destroy tissues that is interfering with the normal transmission of electrical impulse through the heart. So normally people experiencing supraventricular tachycardia and atrial flutter, they use these radiocatheter ablation to destroy the tissues that are releasing impulse to confuse the normal impulse discharge from the SA node. In some cases, surgery may be recommended treatment for heart arrhythmia. So sometimes if medications fail, the last option is to probably resort to surgical intervention to help treat the underlying problem. Patient is reassured to allay anxiety that the nursing measures administer low oxygen by nasal catheter or cannula or mask to patients during tachycardia rhythms to minimize oxygen availability to the myocardium. So you want to maximize oxygen availability to the myocardium because at this point you have low oxygen to move into the myocardial tissue. So you don't want to initiate any angina, so you have to give oxygen nasal or mask to patients so that you can have more oxygen concentration to the myocardial cells. Vital sign is monitored and recorded. Assist the patient with his personal hygiene because they may be weak and cannot do all these activities. Fluid intake and output is monitored and recorded so you don't get fluid overload, which can also affect the problem or the patient. Prescribed medication is given accordingly, and explanation will be given on the importance of taking all medications prescribed. So serve your medications accordingly and explain the importance of serving these medications. So emergency and resuscitation trays should be made available because there could be cardiac arrest at any point in time. The heart can easily stop. Patient is encouraged to rest in bed until the symptoms are treated and subside. Patient is encouraged to reduce stress or lifestyle changes to help limit the incidence of dysrhythmias. Patient is encouraged to know the precipitating factors and educated on the mechanism to limit the dysrhythmias. Once you know that if I do ABC, the arrhythmias may be initiated. Then you will not go and do them, you stop once you know them. Patient is educated to reduce the amount of caffeine intake in the diet, stop the intake of alcohol, and stop smoking. We said coffee can initiate it, alcohol and smoking can initiate it. So once you know it can be initiated, stop it, and that is all. Stroke, complications here. Stroke from heart arrhythmias are associated with an increased risk of blood clot. If a clot breaks loose, it can travel from your heart to your brain. So we have complications from stroke. We said there could be increased risk of blood clots. If clot breaks loose, travels from your heart to your brain, it may be locked within any small arteries, and this can cause ischemic stroke, and if it ruptures, can cause hemorrhagic stroke. Heart failure. So heart failure can also come as a result of poor electrical activity or irregular electrical activity. So heart failure can result if your heart is pumping ineffectively for a prolonged period of time, or due to bradycardia or tachycardia, such as atrial fibrillation. So there could be heart failure. Sudden cardiac arrest, and therefore the need for resuscitation. Cognitive impairment and dementia. If oxygen is not reaching the brain more often, it can predispose you to initiate or have this condition earlier. Sudden infant death syndrome. So if a child is being attacked by this condition, the child can die. So we can have sudden infant death syndrome from this condition. So we will end this point, or at this point, and ask for some questions from you. So we move from electrical impulses, abnormalities, to cardiovascular proper. Here we look at occlusive cardiovascular disorders. So here we look at conditions that can bring about these disorders. So we have first arteriosclerosis. Here we are referring to stiffening or hardening of the normally flexible walls due to loss of elasticity of the atrial musculature. So the normal blood vessels have layers, and within outwards we have tunica intima. So that is within the blood vessels, that lines in there is tunica intima. Then we have the tunica media that is interlaced with a protein called elastin and muscle fibers, elastic muscle fibers. And so when you lose the protein elastin, then you have lost that ability for the blood vessels to stretch and recoil. That ability is lost from a protein called elastin. So the blood vessel remains rigid and stiff, and this can sometimes reduce the lumen within or through which the blood is pumped through for the blood circulation to take place. So once you lose that elasticity, the pressure is always mounted on the heart. So we call it arteriosclerosis. This occurs as a result of aging most of the time. Once you are aging, you are losing the elastin. That protein fiber, elastic fiber, is lost gradually due to generation as a result of aging. As age advances, there is loss of this elastin, causing stiffening of the atrial walls. When young, the arteries are flexible. Of course, a younger person has a flexible artery due to presence of a protein called elastin. But as you age and the elastin starts to decline, the blood vessel wall becomes stiff and hardened. If the walls of the arteries are elastic, they can withstand the turbulence of blood flowing under high blood pressure. Once there is elastin and the elasticity is there, once the blood flows under high pressure, the blood vessels expand and accommodate the pressure. So the pressure does not go back on the heart. As the arteries grow harder and thicker, they become more and more resistant to blood flow, and hence the blood pressure keeps rising as age advances. So as the blood vessels become harder, then it can no more expand to accommodate the pressure. So the pressure goes back on the heart. That is when you have slightly increased blood pressure as age advances. The next one is the atherosclerosis, and you could see the diagram on the right side of the slide, where you see the yellow one is the plaque of fat, which is gradually blocking the lumen of the blood vessel. So decreased blood flow is here, and it's really affecting flow of blood. Look at how the fat has blocked the lumen of the arteries. So atherosclerosis is the formation of plaque within the arterial wall. Atherosclerosis and atherosclerosis are conditions that may begin in early childhood and progress without symptoms throughout life. So this can start very early in life and may not give you any signs and symptoms throughout life. So that is one of the arteries, one of the biggest arteries in the body, the long saphenous vein, building so much fat within the intima, and you can see it on the diagram. So pathophysiology. So atherosclerosis is the narrowing of the artery because of plaque buildup. We all saw how the yellow plaque builds up within the intima of the blood vessels. In atherosclerosis, there is a gradual increase in the deposition of plaque. So the plaque here consists of cholesterol, it has the lipids, the calcium is there, white blood cells, and they all clump together and combine it with platelets. And they plug within the lumen, causing narrowing or at times complete blockage of the arteries. So a plaque is just composition of cholesterol, lipids, calcium, white blood cells, and platelets. They balled up together as a bulk, and they plug themselves within the lumen of the. So it becomes difficult, very hardened to break. Over time, this buildup becomes calcified, very, very hard, and it's not easy to break them. The plaque which is formed within the lumen may be either stable or unstable. So if the plaque becomes stable, then it will be moving. That is, when you are not lucky, it may block a very vital artery. Or could be stable, where it will be at one particular point. Where you are lucky, surgery will be done to break them for you. If unstable, the plaque tears or ruptures, and the blood clot can also form. Sometimes, as it is unstable, it can tear apart and cause bleeding. And once bleeding starts, clot formation is high, and this clot can form anywhere in the body. So this plaque can completely block the coronary artery. So the plaque that has been dislodged, I'm talking about the unstable one, that has been dislodged and is moving up, it can block the coronary artery, or it may break loose and lodge within a smaller artery leading to the heart, resulting in reduced blood flow to the lungs. The area distal to the occlusion may become ischemic as a result. So if the clot forms and there is a vital organ distal to where the clot is formed, you know the blood cannot bypass the clotted area or where the clot has been formed, and therefore that vital organ distal or below the clot area becomes ischemic and dies off. So this is normally what brings about ischemic stroke, and the portion of the brain responsible for this function, the person will lose that particular function. If it is about movement, you lose this particular movement. If it's about vision, the person becomes blind. If it's about respiration, where the person may not survive for a very short time, the person may pass on because it's affecting respiratory center. If it's about whatever it is, the function that is performed by that particular part of the lobe will be affected. The patient has symptoms of ischemic coronary syndromes, stroke, transient ischemic attack, TIA, and peripheral artery disease. So these are the symptoms the patient will be exhibiting. Ischemic coronary syndromes, yes, such as angina, myocardial infarctions, and the rest. Transient stroke or ischemic attacks, and peripheral artery diseases. Causes of risk factors for atherosclerosis. We have non-modifiable risk factors that you cannot control or manage. We have age, and 40 years and above are all at a risk of this particular condition. Gender, men are more liable to developing atherosclerosis than women can. I'm surprised here because the men are more or less active but I don't know, probably it's as a result of the composition of the plaque, which is fat cholesterol. We eat, we drink, we chew more meat than the women. Ethnicity is more restricted to certain ethnic groups. Look at the coastal area. They have weight, they build so much muscles, and they have high cholesterol. If you come to the interlands and then the northern part, they don't have that weight. They are slim, and the cholesterol buildup is more or less low. Genetics. Some family, they are all predisposed to this condition. Hyperlipidemia, it runs in the families, and the possibility of forming atherosclerosis is high. Causes or risk factors for atherosclerosis: we have modifiable, those that we can modify. We have diabetes mellitus, we can manage. We can manage hypertension. We can speak to you for you to change your behavior by stopping smoking, reduce your diet and lifestyle to reduce obesity. Sedentary lifestyle, we can advise you to stop. Increase serum homocysteine levels, an amino acid. We can give you advice and medications. Increase serum iron levels. Infection, depression, hyperlipidemia, excessive alcohol intake. All these are risk factors which we can correct it for you to stop the condition. So we can modify it for you. Then we have the signs and symptoms. We have the dry skin, loss of hair on extremities, pallor in nail beds because of poor blood flow, thickened nail beds, leg cramps because you have poor circulation to the leg, so you feel crampy pains or you feel cramps, cardiac chest pain, so vertigo, sometimes severe dizziness is explained as vertigo, blurred vision, lightheadedness, diaphoresis, you sweat, dizziness, fatigue, palpitation, nausea, shortness of breath, weakness, claudication, pain in the affected part due to decreased oxygen supply. So you feel this pain. Diagnostic test, we have total cholesterol levels above 200 milligram per DL increase the risk of myocardial infarction. So always, if you do cholesterol, please check your cholesterol level, and let's see that your cholesterol level is okay. So if it's okay, that's fine. But if it's high, then there's the tendency to give you medications so you don't risk yourself of causing myocardial infarctions. Blood glucose levels, elevated levels may increase the risk of atherosclerosis. So if you have too much blood glucose level, it will be converted to glycogen and stored as fat, and this fat may cause atherosclerosis. Treadmill testing, a form of monitoring heart capability. The patient is put through a limit of exertion to evaluate ischemia. So they put you on treadmill and then they see at what point you experience chest pain, that is angina. Then they tell us. Digital subtraction angiography is the procedure to visualize blood vessels with contrast medium in a bony environment. So sometimes they want to visualize which of the blood vessels are blocked. So they'll give you a contrast medium and subject it to study. So angiography, they will study it and visualize it. Then the contrast may not bypass the clotted part of the blood vessel. So when it gets there, it will stop. Then they will say, oh, this is where the clot is. So that is what the Doppler ultrasound used to measure blood pressure at various points along your arm or legs and the degree of any blockage. If there are blockage, Doppler ultrasound will identify it. So how do we manage? So diet, low fat, low cholesterol, because of what we are trying to prevent. Your diet should be of low fat and low cholesterol. Smoking cessation is very, very important. Increased exercise will take away the risk of obesity and burn out the atherosclerosis, so that the walls become patent and open. Medications, high dose of statins, that is the Lipitor. They will put you on atorvastatin to break down and reduce the high cholesterol level. Watch for the 5 P's: pulselessness, pallor, paresthesia, and paralysis. The 5 P's: pain, pulselessness, pallor, paresthesias, and paralysis. These things are common with atherosclerosis. So medical management here, anticoagulants used to prolong clotting time. So here we have anticoagulants, so heparin and warfarin. So that is given. So we have anticoagulants. It's used to prolong clotting time, heparin and warfarin, so that the possibility of clot forming is drastically reduced. Fibrinolytics or thrombolytics are used in dissolving existing thrombi, that they are called urokinase. So this medication will, even when the clot is formed, it will break those plaques. They are likely to break the plaques and take away the clot, so that the lumen become patent. Surgeries used for advanced diseases include embolectomy, the removal of embolism or the clot, so that the vein becomes patent. Okay. So nursing interventions here, we have ineffective tissue perfusion related to decreased arterial blood flow, avoid raising feet above heart, keep extremities warm to promote vasodilatation, administer medications as prescribed, teach patients the importance in not making smoking to prevent vasoconstriction, also avoid caffeine, not crossing your legs, not to wear constrictive clothes such as gaiters, tight stockings, or belts. Then we have complications here. Complications of atherosclerosis include coronary artery disease, myocardial infarction, and transient ischemic attack or stroke. So these are all complications that can result. So I think we have done enough, and I will pause here. So you jot your questions and everything, your contribution, jot them down. You will answer them when we meet. Thank you very much for your attention. May the good Lord be with us all till we meet next week. Have a wonderful weekend. Bye-bye.